everyone, and welcome to this 2021 edition of the Dragon's Den competition for Invent. So that's one of our, if not our greater event of the day, of the year. Next. So just for the ones who join and who don't know exactly what Invent is, so it's a network of national research networks. So it's a partnership between 10 clinical research networks around the globe, and altogether we're more than 400 investigators. And what we're trying to do is to support and to promote collaboration between countries for academic peer-reviewed clinical research in venous thromboembolism. Next. So here is a list of the participating members. As you see, it started with a relatively small club, and we are progressively expanding. Right now, it was mostly Europe and North America, but we recently extended to China. So welcome to members of the Cures Network. I know it's late in China tonight, but thank you for joining. And we have some discussions to expand the network further, particularly in South America or also, sorry, I should mention as well, I forgot importantly that Australia and New Zealand have been part of the adventure since the very beginning, and it's even later over there, or very early in the day. So welcome everyone. So what do we do? So I think we are around for 5 years now. It was created 2016 in Montpellier. The SSC meeting, I think, was the first meeting. We endorse studies, so people who want to internationalize our study can submit it to the network, and then we decide whether it's a good fit for the network, and then do some promotion, so at meetings, or try to connect investigators that could have an interest in running the study in their own country. We are trying to financially support investigators as well, and so that's actually our main event again today, the Dragon's Den. And so the best project today will get 40,000 Canadian dollars to try to run. So that would be like 30,000 euros, I guess, or a bit in between in terms of US dollars. And that is aimed at least getting some startup activities, or even being able to do inclusions in other countries. We also have a smaller competition, Kickstarter Award, so stay tuned for that. We advertise widely on internet and on Twitter and LinkedIn and others. And that's for smaller projects, again, startup activities to open in your country a study that's primarily ran out of another one. Beyond that, we're trying to also improve clinical research tools for VTE. So we, thanks to our CanVector network in Canada, we've set up an adjudication platform that we are opening now to any investigator part of the event. We're also trying to do some lobbying or some advocating for clinical research, and we are actually discussing with other similar types of network in stroke or critical care, and they also have the same type of organization and events, and we are aiming to tackle some hurdles to international academic research at the global level. We've worked as well with ISTH on the Common Data Element project. We have a core outcome set projects going on as well. So again, trying to improve and provide tools for researchers in VTE. Next. So how does this work today? So it's a Dragon's Den. So maybe not everyone is familiar with it's a TV show where some new entrepreneur with ideas are trying to pitch ideas to dragons who are investors and who might be interested in investing into their startup company. And so there is a humoristic tone to it as well, and in the way the dragons will try to challenge the entrepreneur, and so on and so on. Next, so our competition is a adaptation of that. So you as the public today, you will have an opportunity to vote, to ask questions as well. Don't believe our dragons. They pretend they're rich and they hold the money, but they don't hold nothing. They just hold their dog. And the money is something that they will be in charge of administering. So look at the famous dog. He's famous all over the planet and the Twitter planet. And so Our dragons, as you guessed, today are Simon Noble and from the UK, formerly from Europe, and Susan Kahn, who is from Montreal in Canada. And I will have the pleasure, so the Wrath of Dragons, and I will have the pleasure to moderate the session. And our presenters today, we have 4 projects. So APICAV, presented by Dr. Galano, and then the DAYS, which will be presented by Dr. Kirsten DeWitt, Prep and Go, presented by Leslie Ski, and Savor, presented by Aurélien Deluc. So without further ado, I will ask, just to give a bit of the agenda. So each investigator will have 5 minutes to pitch their studies, and then they will be questioned by the dragons for a few minutes as well. During that session, you have the opportunity to put any question in the chat, and I will ask these questions to the investigator as well. Then you will proceed to a vote, and the Invent Council will make a final vote ranking and deciding on the winner at a later date. So I think we are ready to invite, and before proceeding, a warm thank you to our sponsor. Without them, nothing of that would be possible, obviously, and they tremendously help in finding the funds and in making that possible. So thank you to all the ones listed there and to all our potential partners as well. Good. Are we ready to start? So Jean-Philippe was the first one called to present your project to the dragons. Off you go.
Thank you, Grégoire. So it's my pleasure to present you the APICAV study on behalf of my co-PI, so Jean-Luc Bosson and Marie-Antoinette Seves from the French Innoviti network. So Grégoire, like me, from the CAN Vector network, and Marc Rigini from Switzerland. So the APICAV study focused on the management of isolated distal DVT, which are infrapopliteal deep vein thrombosis without pulmonary embolism. And it is the most frequent clinical presentation of the venous thromboembolic disease. It represents more than half of all isolated deep vein thrombosis. At variance with some guidelines that do not suggest to treat them with anticoagulation, in routine clinical practice, distal DVT are almost systematically treated with anticoagulant. Why? Because patients are symptomatic, they know that they have a DVT, so they are worried and they expect some kind of treatment. Furthermore, most family physicians do not accept that their patients are left untreated. The optimal anticoagulant treatment in this setting is uncertain. In guidelines, when anticoagulant is considered, therapeutic anticoagulation is suggested. But what we learn from registries is that in routine clinical practice, various anticoagulant intensity are used. In our Cactus trial, as compared with placebo, therapeutic anticoagulation was associated with less VT recurrence and extension, but clearly much more major bleeding. So the clinical question is, could lower than therapeutic dose of anticoagulant achieve a better benefit-risk ratio than therapeutic anticoagulation in patients with isolated distal DVT? The study will be a multi-center, open-label, assessor-blinded, non-inferiority study. The patient population will be patients with acute, symptomatic, isolated distal DVT without cancer or calcification involvement, because we know that those patients require therapeutic anticoagulation. Inpatients are eligible if their expected date of discharge is less than 6 days post-randomization. So it means that our patient population target more than 75% of all isolated distal DVT seen in routine clinical practice. The intervention, after a 1-week course of conventional apixaban 10 BID, patient will receive either apixaban 2.5 BID or apixaban 5 BID for 3 months with 2 follow-up visits at 3 months and 1 year. The primary outcome will be a composite of VT recurrence, major and clinically relevant non-major bleeding at 1 year. The sample size, 1,300 patients, and the study will be conducted in 25 centers across Canada, France, and Switzerland, but we would be delighted if other countries are willing to join us. So the APICAV study is a pragmatic study addressing the management of most isolated distal deep vein thrombosis. So the study should be completed in 5 years, including a 36 months period for patients recruitment. How we will interpret the result of the study? If apixaban 2.5 BID is non-inferior to apixaban 5 BID, it will avoid patients to be unnecessarily treated with high dose of anticoagulant. If apixaban 2.5 is not non-inferior, then this will unquestionably validate the fact that most patients with distal DVT should be offered therapeutic anticoagulation. So the APICALF study is a potentially practice-changing study. So the protocol has been finalized and validated by all co-PI. The study has not been funded yet, but we plan to apply to national institutional grant agencies this fall. The Invent Grant Fund will be exclusively used to help grant submission in each participating country, to facilitate the expansion of the study in other countries, and to strengthen scientific collaboration via funding of a part-time research coordinator and organizing fund conference. So the APICALF study is critical given the prevalence of distal DVT and the need for a consensual therapeutic management. The Invent endorsement and funding are key to successfully complete the APICALF study via the promotion of the study by Invent Council members in their respective country. And for sure, this will help strengthening and it should ensure the success of our grant applications in each of the participating countries. Thank you very much for your attention.
Thank you, Jean-Philippe. Dragons, up to you.
I have a comment. First of all, formidable Jean-Philippe, and a nice follow-up to the Cactus study program. This sounds like a very expensive study, and I'm a very stingy dragon. I don't like to spend my money. So I'm wondering, given how easy it is for a physician just to prescribe a standard dose anticoagulant for CAF DVT, how convinced are you that the bleeding rates will be lower with a reduced dose anticoagulation? Do you have any information based on the literature that you know of?
Yes, so clearly, first of all, regarding the budget of the study, it won't be that high because we plan, because we will do like for the COBRA study. So we will randomize the patient, and then we will give a prescription to the patient of either apixaban 10 followed by 2.5 or 10 followed by 5, and they go to their pharmacy to buy the medication, and they are covered by their local insurance program. So the price of the drug won't be part of the budget of the study. So this won't be an expensive study. So that's the first thing which is important to keep in mind. Second thing, yes, we feel that there is no expected benefit to give therapeutic anticoagulation to patients who have distal DVT without cancer or calcification involvement. So the rate of VT event rate should be exactly the same in both groups. And we know from the studies, the previous study with DOAC, that if you use a prophylactic dose, you will have less bleed. And we have to keep in mind that in our patient population, there will be a patient population of randomized trial. And with our estimate, we will have less bleeding event, but in real life, we have patients which are much older, and for those patients, being on a lower dose will be even more beneficial. So that's why I strongly believe that we should offer to those patients lower dose of anticoagulant treatment, because the expected benefit will be even greater in routine practice. Thank you.
Simon.
Well, first of all, I thought that was a very, very impressive presentation. But unfortunately, I can't be kind to you because having come here in a good mood, Gregoire has basically put me in a bad mood. As you see, he mocked the United Kingdom for coming out of the EU, which, coming from someone who's was described by the president of the USA as a country of cheese-eating surrender monkeys, I felt that that was really rich. So I apologize that I can't be pleasant because he's put me in a terrible mood. pragmatic question. You're making the assumption that these patients must be anticoagulated. Why not have a third arm in which you are actually doing serial Dopplers for these people and seeing whether these, surely there would be some which may resorb, and you're not exposing them to the risk of anticoagulation.
Because we are not doing that, because in routine clinical practice, what we learn from studies is that patients want to be treated. If patient doesn't want to be on anticoagulation, then they can go for serial ultrasound, but that's another study, and we have data from management study that shows that it is safe, but in real life, that's not what is happening. So that's why, as we know that most patients will be offered anticoagulation, we want to give them the lowest dose as possible.
So I accept that. I accept that that may be what is happening, but actually we shouldn't design our studies or even continue our practice on based on that's what other people do. The whole idea of our research is to actually challenge what is being done. I was impressed that you mentioned that this is what patients want. So I was interested in what patient participation involvement you've had in the design of the study and the workup of it.
So the patient, so we have not included patients for now in the development of the study, but we did it previously with the Cactus study, which is a previous study that we did years ago. And what we learned also from the Cactus study is that, the Cactus study, it was therapeutic anticoagulation as compared to a placebo. And we had big issues.
I do read the literature. Thanks, though, for reminding me.
Yeah, and patients did not want to participate because they wanted to be treated. So we already know that they want treatment.
So you don't feel you need to ask patients any other involvement in this study because you know everything a patient has to offer?
No, because no, I agree that it's important to ask to the patient what they are willing to do. But from our previous study, they already told us, and they will be involved. They will be a patient partner, as in any studies that we do with ScanVector and Innovity and all the networks. So patients will give us their feeling before the submission to ethics. So yes, the patient will be involved. We have not involved them yet, but this will be done before ethics submission to make sure that we did not miss something important. But as we have the experience of a previous study, we strongly believe that it is relevant and that it should be acceptable.
Well, I disagree with you. I think patients should be involved at the beginning of each study and throughout it. And I think there's a real value there. And I'm sorry that what you learned from the Cactus study wasn't that we should have patients involved in all the trials we run. But you know that's for your decision.
No, I understand. But you have also the discussion that you have with your patient when you see them at bedside, and when you talk with the patient, they tell you first that they want treatment, and when you told them about the dose, they want therapeutic anticoagulation, because it's not. That's from my clinical experience. So from my clinical experience, I've talked with the patient and I've talked about the dose. So on a practical point of view, it's a kind of, my feeling is that it's a kind of involvement. But I agree with what you say, but they will be involved before final ethics submission.
I would suggest to you that whilst this, what you've said there is very helpful when it comes to implementation and dissemination, I believe the patients have a very strong role in actually contributing to the design of the study, how the study is monitored, and also, from my experience, and also the experience of the UK Patient Partners Forum, it actually they'll have some fundamental advice for how to make randomization, how to make recruitment easier based on what they as patients feel. And so I think the advice that you've had from your patients there would also be very useful throughout the design and conduct of the study. Something to consider.
No, but I think,
sorry.
and we will, And we will ask the patient, we will ask to our patient partner what they're feeling before finalizing all of that. Yeah.
So I hope you had a chance to vote. One last question from Roger. Quick question, Dr. Roger. Quick answer. Oh, Roger. Oh, what's your question? I see you have a question. I can't see it.
In the chat.
In the chat. Yeah.
Oh,
Indirect
it's
comparison.
gone. It's gone from the chat.
Okay.
I think the question was similar to what I had asked about the data to inform that there might be a difference in bleeding risk between the full dose and low dose apixaban.
Yeah, so we made our estimate based on the DOAC study and also based on the TICT study, which is an Italian study that had it was a management study. And so there was no comparator, but they had patients on full anticoagulation with low mol for 1 week, and then an intermediate dose for 3 weeks. So then we had an estimate of the risk of bleeding with patients that are fully anticoagulated, then dose reduction.
Perfect. Sorry, we have to move on. Thank you, Jean-Philippe. So our next speaker is Dr. Kirsten DeWitt, who will present on the DAYS project. Dr. DeWitt.
Thank you so much for allowing me to present on the DAYS pilot study. This is a collaboration between CanVector and the Dutch Thrombosis Network. The Wells model for deep vein thrombosis diagnosis was first published in 1995. And 2 years later, a simplified version of this model was published. This is the same model that we use today. There are 9 components, and some components have multiple items. So when a physician applies the Wells score for deep vein thrombosis, they have to assess a total of 13 items. We previously interviewed emergency physicians to establish how they test for deep vein thrombosis, and we found that they don't use the Wells score, often opting for a standalone proximal ultrasound instead. When we asked them why, they said,
"The challenge would be just to memorize it."
Wells, there's too many variables.
Wells is long. There's always one element that I usually forget.
Taking the time to sort of look up the tool and what have you, it might only take a minute, but it's a minute where you could have been seeing the next patient or finishing up your charting or whatever.
Using this information, we derived a new simple decision tool for deep vein thrombosis testing. We used individual patient data from 4 previous diagnostic deep vein thrombosis studies, and we modeled this new decision tool on the years decision tool for pulmonary embolism testing. Because it's modeled on the years, we called it the DAYS algorithm for deep vein thrombosis testing. It consists of DVT being the most likely diagnosis, there being calf swelling of a minimum of 3 centimeters of the affected leg, and D-dimer. Not only is it a simple test, but is also highly sensitive, moderately specific, and in the derivation cohort, it was able to rule out deep vein thrombosis without imaging in 43% of cases. So the aim of this pilot study is to assess the rate of recruitment to the study, 90-day loss to follow-up, and to estimate the proportion of patients who have deep vein thrombosis excluded with and without deep vein thrombosis imaging. This is a prospective management study. It's conducted in emergency departments in Canada and the Netherlands. The patient is recruited if the physician tests them for deep vein thrombosis of the lower limb. There will be 250 patients recruited to the pilot study. The exclusions include being anticoagulated, under the age of 18, having previously been diagnosed with deep vein thrombosis when there's no baseline imaging accessible, or presenting with symptoms of pulmonary embolism. If the emergency physician knows the results of the D-dimer before they calculate the DAYS items, then the patient will not be included. This is the DAYS flowchart. So the physician starts with assessment to see if deep vein thrombosis is the most likely diagnosis or whether there is more than 3 centimeters of calf swelling. If neither exists, then they will use a D-dimer threshold of 1,000 nanograms per mil to exclude deep vein thrombosis. If either of those exist, then the physician will use a D-dimer threshold of 500 to exclude deep vein thrombosis without diagnostic imaging. The outcome for the full study is the false negative rate, which is the rate of pulmonary embolism or deep vein thrombosis diagnosed within 90 days of having negative testing using the DAYS algorithm. This is independently adjudicated blinded to the DAYS score. The pilot study, however, will be assessing the patient enrollment rate per site per month that we estimate should be a minimum of 5. The proportion of patients who cannot be reached at 90 days for their follow-up, and the proportion of patients who test negative at their initial deep vein thrombosis assessment, along with the estimate of the DAYS algorithm efficiency. We already have a grant from Queen's University, which covers a cost per patient recruited, which will be sent to recruitment sites. We need further funding to fund a part-time study coordinator. So in conclusion, the WELL score is complex and is seldom used. The DAYS score is simple. We propose a pilot study which will lead to an international study which we hope to include multiple INVENT members in to assess the safety and efficiency of DAYS testing for deep vein thrombosis. And DAYS has the potential to change emergency medicine practice. I'd be happy to take questions.
Thank you, Dr. David. The Dragons, the floor is yours.
I'll kindly let Simon go first this time.
Thank you very much. I don't know if Phil Wells is watching this, but I can imagine him desperately trying to record that soundbite, Wells is long, and playing it to himself over and over again. Kirsten, my first question is, as a Scot, I'd just like you to say, who do you think's the best football team in the Euro 2021 at the moment?
You know what? I am not a soccer team fan.
I don't care.
But I did hear on the grapevine that maybe England are in the finals.
England are most definitely in the finals. So, Gregoire, you just remember that next time you diss me.
What about Wales?
Shush. Are cancer patients excluded from this because of my concern being the elevated D-dimer?
Absolutely not. In fact, I have been heading a whole program on producing standards for the ISTH in cancer patients for testing for deep vein thrombosis. And we've just completed a systematic review and meta-analysis that shows that D-dimer is highly sensitive with a standard cutoff of 500, even in cancer patients. We've also established that the utility is around 10 to 15% in cancer patients with a negative D-dimer. Thank you.
And then my next question, I know that Long Phil Wells will be very sad to know that despite his wonderful work, people aren't using it. How do you know that the short days is going to be used? Because that's the only way. You say it's practice changing. No matter how bright and sparkly it is, if people don't use it, it's just another, it's as much help as a 17th meta-analysis of DOACs versus low molecular weight heparin in cancer.
You're exactly right. I intend to implement the study here in Canada by having the DAYS become the standard algorithm in participating emergency departments. So we will have the opportunity to evaluate the uptake of the DAYS algorithm. If the patient's tested for deep vein thrombosis by using another algorithm, then they're not eligible to participate in DAYS. So we'll be following the missed eligible cases with this pilot study.
I'm now very happy to hand over to the great Dr. Khan.
Thank you, Dr. Noble. So Kirsten, you're an emergency medicine physician, aren't you?
Correct.
Okay. The stereotype on Twitter is that all emergency medicine physicians wear Patagonia sweatshirts, they ride their bikes to work, and they like to keep things simple. And I have the same concerns as Dr. Noble. I know that this work builds on the 4D study and PEGED, where clinical probability adjusted D-dimer is used for diagnostic management. But I also wonder, what is the uptake going to be in a very busy emergency department of having to figure out whether the D-dimer is above this level or below this level, and that somehow guides management? What do you think?
I think that's a really important point. I think one of the important ways to implement this is through the electronic medical record, so that the physician is guided. So for example, when they order the D-dimer, if they're testing for deep vein thrombosis, they have to enter the day's items, and that will tell them what the D-dimer cutoff is that they should use. So we have to automate this as much as possible.
Kirsten, since you are on the D-dimer cutoff, there was a question from Alison Bond asking, are all D-dimers interchangeable?
Yeah.
And what do you plan to do for that?
Yeah, sorry, I missed the full question, but I think perhaps you're referring to, can we use all D-dimer assays? Yeah. So we will only include a recruitment site if their current assay has a manufacturer recommended cutoff of 500, or depending what units used, but in nanograms per mil, 500. So we won't be using any sites that are already using a D-dimer that has a different cutoff. For example, some versions of the IL test, you have a cutoff around 270.
Good. One last burning question from the Dragons, or can we, or from the audience, or can we move on? Yes, we can. Very good. Thank you, Kirsten. So our next presenter is Dr. Leslie Skees from Calgary, and she's presenting on the Prep and Go project. Leslie, up to you.
Hi, Dragons. I'm Leslie Skeeth.
Isabelle Malamé.
And together, on behalf of our investigators, we are presenting Prep and Go, a peripartum anticoagulation management study. Let's cut to the chase and the bottom line. Dragons, we are asking for $40,000 to complete an economic analysis sub-study of Prep and Go, as well as having additional funding for our US site. And what will you get in return? What's your return on investment? You will be able to strengthen 5 research networks across 13 sites for this CIHR-funded study, and we will help you advance the Verdict online adjudication platform hosted by CanVector and supported by Invent, by helping to build new ISTH peripartum bleeding definitions into the platform. Because there could be different anticoagulation management strategies by physicians, we will also take an innovative approach to your platform and actually adjudicate the individual strategies so we can classify them and categorize them for analysis.
So of course, to inform decision-making surrounding peripartum anticoagulation, we will have to take into consideration thrombosis risks, bleeding risks, and patient preferences. But at the end of the day, maybe none of these can be implemented if your healthcare systems cannot withstand it. And so it is crucial to understand resource utilization associated with each anticoagulation strategies, because cost matters.
Prep and Go is a pragmatic, unique, prospective cohort of pregnant women on low molecular weight heparin for either a VTE or those at risk of VTE, such as a potent thrombophilia. We will be systematically tracking our participants throughout labor and delivery, as well as the immediate, early, and late postpartum periods. Our study also includes patient questionnaires, pre and post delivery, as well as blood work, including a CBC and anti-10A level. This is pragmatic. We have the option of doing postpartum visits by phone at 6 weeks and 90 days.
Our primary outcome will focus on the combined incidence of major bleeding and clinically relevant non-major bleeding for up to 6 weeks postpartum. Importantly, we will be featuring for a first time the new ISTH peripartum bleeding definition, which has been developed by members of our team. This novel outcome will be adjudicated among 825 women recruited from 13 participating centers across 6 countries.
This study and this sub-study is really about healthcare utilization. We will be collecting resources available at each of the centers, as well as data relating to length of stay, postpartum and total hospital length of stay, induction of labor, repeat procedures, and rehospitalizations. If there are differences in resource utilization across different anticoagulation management strategies, we will be completing a cost analysis based on published cost data. If there are clinical outcomes that differ across management strategies, we will be completing a cost effectiveness analysis. And this is where we need your help and your funds to support additional statistical and database support. We have the perfect person for the job. Our collaborator, Dr. Jeff Federspiel from Duke University, is the triple threat. He's an obstetrician, maternal fetal medicine specialist. He has training in thrombosis under the mentorship of Dr. Andrew James, and he has a PhD training and experience in healthcare utilization and cost effectiveness analysis.
So Dragons, we will provide you with accurate information on the risk of VTE, peripartum bleeding, and patient preferences around labor and delivery. Importantly, we will get to understand how best to optimize care to benefit the most people. Now back to you, Leslie, for concluding remarks.
In summary, we will provide you with high-quality data to implement patient-focused decision-making in your healthcare system. And Dragons, we are ready to take your questions.
And your offers.
Thank you, Dr. Malame and Dr. Skeeth. And Dragons, the floor is yours.
Okay, so maybe I'll go first this time, if that's okay with you, Dr. Noble. So Leslie Skeeth and Isabel Malame, very persuasive presentation. And Leslie, we all know that you're the master at study acronyms. So you found another good one here. And thanks for reminding us, Dragons, that cost matters. We are asked to judge whether studies will change practice. So please let us know, in what way do you anticipate that this descriptive study will have implications for clinical practice?
We really have a lot of practice variation across centers, across the world around anticoagulation management, around delivery, in part due to very limited and retrospective data that has different definitions of bleeding and how this bleeding was collected. And in the future, we will be planning a future randomized controlled trial. But really our first step is to get that data and get the information to the hands of patients and providers. And so by tracking and using standard and now new definitions of bleeding, our VTE definitions, and really incorporating and understanding patient preference and healthcare utilization, we think this is a next big step for giving information on what strategies may be acceptable or not acceptable based on standardized data.
In addition, if I may add, anticoagulation practices surrounding the peripartum period are intimately linked to the management of delivery, and from an obstetrical standpoint, the management of the DVT risk or the actual DVT may have an impact on healthcare utilization in the obstetric setting. And so this will be a holistic approach to understanding anticoagulation strategies in light of the global system in which the patient is in.
Great. In the interest of time, I'll pass on to Dr. Noble. Thank you.
Thank you both for that very slick presentation. I'm interested to know a bit more about this questionnaire, which is going to evaluate patient preference.
It's a great question. We have developed the questionnaires.
I'm a dragon with good questions, you see.
excellent question, Dragon.
Good.
We have a pre-delivery questionnaire, which in part is about expectations and choice. We will have a direct choice question because there are competing risks of epidural use versus bleeding risk and VTE risk. So we do have a little bit more focus on those different options. And then postpartum, more focus on satisfaction, what happened, and that expectation around what happened around labor and delivery and matching it with their expectations.
So how's this been designed? What are the processes that have led to this being designed? We've not pulled off the shelf some standard questionnaire here.
There is no no questionnaire that has been previously studied. So our first step has been to develop it with our group, with input from 2 patient partners, and we will be piloting this questionnaire and potentially going into a little bit more detail relating to interview or to kind of the pilot walkthrough of the questionnaire to test it out.
Okay, thank you. Final question from me. You're talking about doing health economic analysis. Within the United Kingdom, when decisions are made about various interventions, the health economic analysis will actually have a threshold number of quality adjusted life years for it to be considered financially viable. Do you have such a target from a health economics perspective in your study?
I think one of the challenges and the benefits of doing an international study is that we will complete a cost effectiveness analysis, but look at it with a different lens depending on the country, for example, Canada versus US or the UK or Europe, or may have differences. So we will be looking at that. That cut point of the 50 to 100,000 QALYs may differ across countries and across institutions. So we will have one, but look at these different metrics according to the country.
Again, one of you buggers goes on about the UK and Europe. Stop rubbing it in. It's not my fault. We made a mistake. They made a mistake. Bloody hell. Just not fair. Don't you do that to me, Dr. Khan, you meanie.
All right, any question from the audience? Not that I can see any. Suzanne, any final word before we move on? Are you good? Good, great. Well, thank you, Dr. Malamé and Dr. Skeet then, and for your presentation, and we'll move to the last presentation of the day. So it will be Dr. Deluc presenting on the SAVOR project. Aurélien, floor is yours.
Thank you. Good afternoon. My name is Aurélien Deluc. I'm a thrombosis doc in Ottawa. And today I would like you dragons to invest your invent money in my randomized controlled trial. You know that despite our best care with this, that, or even this, sorry sponsors, many patients will experience VTE recurrence. From 1% per year in persons with unprovoked VTE who stop anticoagulation to 10% per year on anticoagulation in people with cancer-associated VTE. Look at this bottle. It contains a drug that has the potential to reduce the risk for VTE recurrence by 30% without increasing bleeding rates. Dr. Khan, this drug might even reduce the risk of PTS. Isn't it amazing? Side effects are infrequent. Millions of people around the world are taking daily. It's even available over the counter in the UK, not in Europe. Have you ever thought of such an amazing drug? The dream of all thrombosis physicians. Numerous cohorts, case-controlled studies, and meta-analysis suggest this drug can reduce VTE in all categories of patients, men and women, obese and non-obese, those who had a provoked or an unprovoked VTE, even in patients with cancer-associated VTE, Dr. Noble. This incredible drug is taken once a day during anticoagulation and after anticoagulation ends. So you are wondering, what's the name of this drug? This drug is rosuvastatin, or could be a placebo. Indeed, we must demonstrate this magic drug actually works to prevent recurrent VTE. A pilot trial demonstrated the feasibility of the full-scale study. So I'm sorry for this. Yeah. 312 patients were enrolled in the trial. And this pilot trial was performed in 6 different sites in Canada and Norway. And it has demonstrated the feasibility of a larger scale trial. 20 patients, I would say 21 patients as of today, are currently enrolled in a full-scale trial. This trial has opened in Canada, will open soon in Norway and France. And we need our separate dragons to coordinate opening sites in the European Union and help coordinating the opening of Germany. So we received funds from CIHR in Canada, PHRC in France, Ministry of Health in Norway to run the trial. But we need Invent to help opening the centers in Germany and to coordinate in the European Union. So what is SAVOR? SAVOR is a trial where we include symptomatic proximal DVT and OPE patients who are included 30 days prior to the randomization. We will stratify variables by center, by provoked or unprovoked VTE. The choice of anticoagulation duration is at the discretion of the investigator, and this is an event-driven study. So we plan on including 2,700 patients. They will be randomized to rosuvastatin, 20 milligrams daily, or placebo on top of their standard of care of anticoagulation. They will be followed for 6 to 60 months. And the primary study outcome is the rate of recurrent major VTE event. And one of the secondary outcomes is the incidence of post-thrombotic syndrome. Like I said before, the study is already funded by CIHR in Canada, by PHRC in France, and in Norway as well. Sites have already opened in Canada or are currently opening. In Europe, all the Invent countries are involved in the study and agreed to participate and include patients. The aim of the Invent Dragon's Den competition fund would be to open Germany, as I said, and to help coordinate the European Union centers. Australia will also participate in the study. They are seeking for funds. So I'm happy to take your questions, dragons, your remarks. I had a final slide that I cannot show you, but I'll try to manage that while you are asking your questions. Thank you.
Okay, so my turn to start. Thank you very much for that. Can you just expand a little bit on your feasibility study? Because you said, you know, you recruited just over 300 patients. How many patients were screened, and how many patients then who were you went to recruit actually went into recruitment?
Yes, so thank you. That's the toughest part. So basically, so basically that's the so 3,000 patients were screened, but most of them were excluded because they already had an indication for taking a statin. So once you exclude these patients, there were about 900 patients who were eligible. Then we had to screen for a potential indication for primary prevention. So it left these 300 patients. And this is a major limitation, of course, of the study. So to simplify that, we changed the inclusion criteria. So the inclusion criteria for the pilot study was no indication for statin, even for primary prevention. So we just skipped that and changed it to no indication for statins for secondary prevention. And we will not screen all patients for their cholesterol levels to make it more pragmatic. So it has to be as pragmatic as possible, even if it's a placebo-controlled trial. But yes, there's a lot of people who cannot be included just because they couldn't be included because they had an indication, a potential indication for statins.
Okay, Dr. Khan.
So excellent, Dr. Deluc, and thanks for mentioning PTS for my benefit. For those of you who don't live in Canada, this doesn't show, okay. It's a $50 bill, it sort of looks like Monopoly money. But before deciding about spending our hard-earned dollars on your trials, I have a question that pertains to feasibility. I'm just wondering in the pilot trial whether you got any pushback from the younger patients with VTE who didn't want to be on some old geezer drug like a statin. Do we have information on that?
No, sorry, I don't have the mean age of people who refuse to participate, if that's the question. So I don't know if it's older people or younger people. It's true that older people will be more likely to have an indication to statins. And so what struck me when we analyzed the data of the pilot was the age of the mean age of the patients who were included, because we had this, and it was a little bit younger than 50. So which is unusual in the VT studies. You would expect 55, 60. So most of the patients who were included in the pilot were young, because the older had an exclusion criteria. They had an indication for statin.
Okay, and just a final question. I mean, we do know that statins can be associated with, annoying and symptoms like muscle cramps and aches. And were those effects tracked in the pilot study? And could that be a limiting factor?
Yes, it was tracked. So there were some side effects like this. Only one patient had an increase in his CPK levels. But what I wanted to say about that is this very interesting study on the placebo effect or the nocebo effect, because there are publications that show that the rate of side effects from statins are the same when patients are on statin or think they are on a statin. So I expect side effects, but I'm not sure it's going to be a major limitation to this study.
Thank you.
Good. Simon, any other questions to Aurélien?
No, thank you. I kind of lost it during the last answer, so no, I just need to lie down now.
Suzanne, the audience, any questions there? No? Well, Aurélien, you had a good rate of people saying that would change practice, so that's already encouraging.
Yeah, and I think if your research doesn't work out, Aurélien, you could do stand-up comedy as a career.
Thank you.
Good. No final question. Very good. So thank you everyone to have played the game. Thank you to the Dragons. I know it's not a easy exercise to pretend to be mean, but I think you did it pretty well. I was impressed, you know, and presenters and ways to answer questions. And obviously it's more fun when we're together, and hopefully that will happen next week. We'll be able to be in the same room and make more fun of the UK than today. And we'll announce the winners on July 20, social media, everywhere, email, so stay tuned. And thank you everyone for attending today, and again, see you next year. Bye everyone.
Bye-bye.
And don't forget to send us feedback or suggestions for Dragons or anything that you think could help making that event even better. Bye everyone.
Well done, everyone.
Thanks, Gregoire.